a lot of men have to deal with, and that's myself included. So I'm also a patient as well as a doctor. So I understand a lot of these things, and my father has had experiences with this also. He's in his mid 90s and still going strong. So I have been in practice of urology for over 36 years. I trained in Los Angeles, and I practiced in Boston at New England Medical Center for approximately 30 years. And I've been here in the North Country for over 5 years. I go to Androscoggin Valley Hospital in Berlin, New Hampshire. I also go to Lancaster, which is Weeks in Lancaster, and I go to Colebrook, Upper Connecticut Valley Hospital. So I cover the three North Country healthcare hospitals. I really enjoy what I do. I enjoy helping people. I'm a surgeon. I am also a generalist who I think knows a lot about these conditions. And hopefully I can answer your questions that you have, and don't be afraid to speak up. We're all in this together, and I hope you learned something tonight. There should be no audio and video recording during this presentation. What we'd like to cover tonight, we'll give a general overview of prostate, what the prostate is, what it does, some of the problems that it creates, and then we'll talk about BPH, which is the main discussion tonight, refers to benign prostatic hyperplasia, or an enlarged prostate. And we'll talk about medical and surgical treatments, and then we will have a question and answer period at the end. So to begin with, let's just talk about the prostate. It's not prostrate. You hear that said many times. Always good for a laugh. But prostate, the prostate is a small walnut-sized gland at the base of the male bladder. It surrounds the urethra. So basically, you can think of it as a donut, and the opening of the hole in the donut is the middle is called the urethra, the prostatic urethra. So it actually surrounds the urethra. It produces fluid that transports the sperm and also nourishes the sperm during ejaculation. And with time, and extremely variable, the prostate does grow in size in most men. It's normal size usually up to the 40s, and by the mid 40s, the prostate starts to grow. We do not know of conditions that actually cause it to grow. It's mostly genetic, definitely strong family history is involved, but people always ask, what can I do to prevent the growth of the prostate? And we do not really have any things to do as far as lifestyle things to change, diet, exercise. They potentially can help prevent prostate cancer, but it does not seem to change the growth of the prostate.
Dr. Rittenhouse, I'm sorry, do you mind just speaking up a little bit? We're getting some feedback that it's a little bit low.
A little bit low. I can turn up the volume.
That'd be excellent. Thank you.
Is that better?
Are you guys hearing him better on the other end?
Is that better?
I'm hearing you loud and clear. Yep.
Okay. Very good. Thank you.
A little bit louder. Sorry.
Okay. Go all the way up here. So,
awesome.
All right. Thank you. What can happen to the prostate? Basically, what are the conditions of the prostate? The three common conditions that we treat and see are an enlarged prostate, which is BPH, which we're going to mainly focus on tonight. But there are other two main conditions that are basically intertwined, oftentimes related, or can be found together, coexisting. One is prostatitis, which is inflammation of the prostate gland. That's oftentimes presents with fever, painful urination, infected urine, positive urine cultures, and that is definitely associated with an enlarged prostate, but can also happen in younger men with a normal prostate. So it's not confined just to BPH patients. And then prostate cancer, there's overlap with prostate cancer in all of these conditions, and that's why it's important if you're having symptoms to be evaluated by your medical physician or urologist, can help determine which of these conditions are involved and give appropriate treatment. So okay, what is BPH? BPH, as we said, is benign prostatic hyperplasia, commonly known as an enlarged prostate. It means it's grown in size from normal, which is say walnut size, about 1.5 centimeters in diameter. Or if we go by cc's, it's usually about 20 cc's is considered the normal size, and it can get up to 10 times that. I've seen prostates that are 200 and 300 cc's, and there's even been reports of prostates over 1,000 cc's. So it can grow quite dramatically. But most of the time, enlargement, where most people have the prostate, I'd say within the 30 to 80 cc range that I see in common everyday practice. Conditions that it causes are something called bladder outlet obstruction, which causes lower urinary tract symptoms. We love to use different shorthand. So BOO and LUTS are common shorthand that we use for these conditions. There's benign tissue usually on the inner part of the prostate, which is called the BPH, and then prostate cancer oftentimes develops on the outside of the prostate. And that's why you can feel sometimes prostate cancer when you do a prostate exam. Does BPH mean that I have prostate cancer? And that's a very affirmative no. That's a very no. There's really no association between BPH and prostate cancer. BPH is not prostate cancer. It does not cause prostate cancer. There can be similar symptoms though, so that's why it's very important to be evaluated. And BPH obviously can coexist with prostate cancer. The main way we diagnose prostate cancer is through PSA screening, which has been shown to be beneficial. Long-term studies have shown that for every 1,000 patients that are screened, approximately 2 to 3 patients their lives are saved from dying of prostate cancer, which is very similar to a screening with mammograms in women. So you have about a 60% less chance of dying of prostate cancer if you're doing PSA screening. PSA screening is recommended now between the ages of 55 and 70. It is controversial, but I think as we become more and more sophisticated with diagnosing prostate cancer, I think it's less controversial. Most doctors do now recommend screening, also in high-risk men, such as a family history, African Americans. Those are higher risk. We sometimes will consider screening earlier, or if we find an abnormal exam. As the prostate enlarges, it causes pressure on the urethra, which then causes obstruction. So basically the donut hole is getting smaller, and as the prostate enlarges, and it's simple physics. The bladder pressure will increase, and the urinary flow will decrease. So sometimes we'll do pressure flow studies, which is called urodynamics, to make a definitive diagnosis. Now there is also a newer device called the Eurocuff, which does not require catheterization, and you can determine the function of the bladder without having to pass a catheter. It's done with a small cuff around the urethra, and it's non-invasive, and it's very specific for obstruction from the prostate, because not all symptoms of true of LUTS are actually obstructions. Some patients have a bladder that just does not contract, related to various neurologic conditions, and that can be confused with an enlarged prostate or obstruction. So we obviously get a full medical history examination to determine whether or not somebody has neurologic conditions that may be mimicking the symptoms of an enlarged prostate. Interestingly, though, the size of the prostate does not correlate with the degree of obstruction or the severity of obstruction. So it's kind of counterintuitive. You'd think as the prostate gets larger, the symptoms are going to get worse. But Gentlemen sometimes with a totally normal size prostate can have severe symptoms and even retention, and that's called bladder neck obstruction. There's also a form of that in children called posterior urethral valves. But so the size on exam or on ultrasounds or CTs does not correlate with symptoms. Very large prostates, I've seen gentlemen with prostates 150, 200 cc's that have almost no symptoms at all. So that's, it's very interesting. The alternative though, is also true. People can have significant problems from the prostate and not have any symptoms of prostate problems, could do and not have LUTs. We call that silent prostatism. And that's always a concern because silent prostatism can lead to kidney problems, even kidney failure. What happens is it's such a gradual process that the body is able to adjust, and patients aren't aware that their prostate is giving them problems. So what happens is sometimes patients will just present with an elevated creatinine, which is a measure of kidney function. And then further evaluation is done with an ultrasound, which then shows elevated residuals after urinating, and that puts pressure on the kidneys. So I think men over the age of 50 should be, have general physical exams, lab work to make sure they don't fit into this category of silent obstruction, because it is a very potential serious problem and can lead to kidney failure and even need for kidney transplants. It is important, I think, for men to have yearly laboratory work, especially kidney function tests, PSA as it is appropriate. So I just would encourage men to see an internist, to see their family medicine doctor, because it's always good to work with prevention rather than trying to cure. An ounce of prevention is worth a pound of cure, and I agree with that wholeheartedly. Obviously, there are potential issues with doing a lot of tests where you find what are called incidentalomas, and that is an issue. But in general, I think it's a good idea to see your doctor over the age of 50, maybe even 45, to see a general medicine doctor on a yearly basis. They can help to promote wellness. They can hopefully prevent cardiac issues, which is the #1 killer, and certainly early diagnosis of various types of cancer. So I would encourage that. Unfortunately, men tend to be a little bit more stoic, and they don't oftentimes see doctors when they're in their teens and 20s and 30s, whereas women are kind of used to going to doctors, especially when they are child bearing age. So men really need to, I think, be evaluated. And now it's easier than ever because we are promoting telehealth, and I think that's going to be better and better. So there are many options now for general health measures, and I think more and more internists are now really working on prevention and lifestyle issues to prevent disease rather than just treating them. But unfortunately, as I said, there's really no lifestyle issues involved with the enlarged prostate. There are with prostate cancer, but not with BPH. So what are the symptoms of BPH? Sudden urges to urinate, we call that urgency. Occasional burning with urination, even if you don't have an infection, you can still have burning, and that usually indicates a spasm of the prostate. A weak urinary flow, frequent urination during the day and especially at night, which is called nocturia. A feeling of incomplete emptying of the bladder. That unfortunately is actually a very poor indicator, because patients can sometimes feel like they empty completely and they don't, and and the vice versa is also true. So you really, that's why we use a bladder scanner on many patients, which is a non-invasive ultrasound of the bladder to determine whether or not the patient is completely emptying their bladder. That's probably the #1 thing that we focus on is how well somebody is emptying their bladder, as far as the treatments and the potential for need for further treatment if one treatment is not successful. We subdivide symptoms into and basically irritative symptoms and obstructive symptoms. So irritative symptoms are frequency, urgency, getting up at night, and obstructive symptoms are slow urinary stream, a feeling of incomplete emptying, waiting to get the stream started, and then post-void dribbling. BPH can affect the quality of life. Up to 95% of men with moderate symptoms are unhappy and really want to be treated because they don't want to spend the rest of their life with these symptoms. 49% of men experience sexual problems associated with lower urinary tract symptoms. Some of them are related to the treatment. Some of the medications and treatments do affect sexual function, but fortunately, this is improving with some of the newer treatments. 51% of men with BPH say it interferes with aspects of their normal life, and it obviously can interfere with the quality of life and the quality of their spouse's life too. Who gets BPH? BPH is the most common prostate problem in men over 50. It affects up to 50% of men by age 60 and up to 90% of men by age 85. You can see there are 14 million men who have lower urinary tract symptoms. How is an enlarged prostate diagnosed? When you come to a physician, you'll get a medical history and physical exam. The way we evaluate the prostate is by what's called a digital rectal exam. Many internists now and family medicine doctors do not perform the digital rectal exam, and that is perfectly appropriate. Have to discuss though patients with the possibility of getting a PSA level. With a normal PSA, the chance of having prostate cancer is extremely low, but it's not zero, but extremely low. We also do various non-invasive studies like a urinary outflow test, which is called a Qmax, where somebody will void into a container, which then tells the flow rate, and that's compared with the normal flow rate. And also, like we talked about before, getting a post-void urine volume is extremely important with patients with symptoms. There are also various indexes, self-evaluation scores. We use mostly the International Prostate Symptom Score, called an IPSS, and that's subdivided into moderate, mild, moderate, and severe symptoms. And the treatments then are kind of directed at the symptoms, what the patient's desires are, and what type of procedures they're interested in having. So now we will progress to the different treatment options for patients with enlarged prostates, lower urinary tract symptoms, and bladder outlet obstruction. We subdivide these into behavioral modification, first-line therapies, and surgical procedures. So that would also be fairly correlated with mild symptoms, which would be behavioral modification, moderate symptoms, first-line therapies, and severe symptoms or urinary retention with surgical treatments. And as you can see below, it goes up the invasive scale from low to high. We're going to focus quite a bit on the first-line therapies, mostly REZUM, which is probably the newest, one of the newest treatments, which is quite, I think, going to revolutionize the treatment of BPH, especially for the moderate symptoms with moderate symptoms, patients who do not want to take medications indefinitely. But it also does have some utility in patients with severe symptoms and even urinary retention in certain circumstances. So it is quite flexible, and we will talk about that at length. Behavioral modifications, obviously limiting fluids if somebody's voiding frequently, limiting fluids, maybe changing medications. Some of the diuretics obviously will cause frequency, hydrochlorothiazide, Lasix. A lot of patients don't really, it doesn't really bother them, and they don't mind, a diminished stream, maybe going a little bit more frequently during the day, getting up once or twice a night, and that's perfectly fine as long as they're comfortable with that. They're in patients with mild symptoms that want to be treated. I will oftentimes offer them herbal therapy with saw palmetto. There are a lot of studies on saw palmetto, but none of them have really shown a obvious benefit, but there's definitely a placebo effect, and a placebo effect can happen in up to 30–40% of men. So I think it's not unreasonable if somebody wants to take over-the-counter medications such as saw palmetto. Most people have heard of things like super beta prostate and similar medications. I think they're safe, but they have probably limited value, but I don't think it hurts to try. Kegel exercises, that's where you squeeze the pelvic floor muscles. The way you learn to do that is when you're voiding, shut off the stream, the urinary stream. Also consider it's what you do to prevent passing gas in public. Women use that a lot for helping with bladder control, with preventing urinary incontinence, but it is also helpful in men. It has been shown to improve sexual function also. So I think doing Kegel exercises is an important thing in men for a number of different options. It also helps with urgency. So if somebody has a sudden urge to void, if they do tighten the pelvic floor muscles, they will have potentially a signal sent back to the brain to relax the bladder. So we also have something called biofeedback that is available. We use this in men that have pelvic floor dysfunction. We call that pelvic floor myalgia. There is various types of biofeedback that can be helpful with those type of symptoms. First line therapies, the medications, which we'll talk about in a second, REZUM, and then various types of permanent implants. Then the surgical treatments have varied extensively over many years. They've advanced also, and the main treatments now for surgical is, I think, green light laser. The TURP, or transurethral resection of prostate, has been used for decades, and it's highly effective, but it's a little more invasive. Recovery's maybe slightly longer, and does require hospitalizations for most procedures. For very large prostates, there are open prostatectomies, and now there's also a procedure called the HOLEP, which can be done transurethral for very large prostates, which is a highly advanced treatment for very big prostates. Alternative medicines, like we talked about, there's really been no dietary supplement that has been shown to cause definitive improvement long-term in lower urinary tract symptoms. Watchful waiting is just adjusting fluids, medications that may be causing symptoms. Disadvantages that the symptoms may worsen, and the prostate will continue to grow and cause problems in the future. Medications. There are many different types of medications now that are used for enlarged prostates. I think the go-to drugs now are alpha blockers. The most common one that people have heard about and that I use is called Flomax, or tamsulosin. It is highly effective. It works rapidly, and it has a very durable response. Patients usually notice an improvement within a few days to a week, and can be quite dramatic. I mean, people sometimes can go from voiding 3 to 4 times a night down to 1 or 2. Improvement of urinary stream by up to 30 to 50%, less urgency, less hesitancy. So it can have quite dramatic effect immediately, which is nice. And that's at least it also helps you to know then that the symptoms are related to BPH. So if somebody responds to these medications, it's prostate related, and it's not related to bladder dysfunction or a urethral stricture or some other condition that causes obstruction. There are other alpha blockers. The other ones use Eurolift, which is alfucisin. That seems to cause a little less ejaculatory issues. The problems with alpha blockers is that it does, when you ejaculate, there's less sperm that comes out, and that can be doesn't affect the sensation or the ability to have an orgasm, but there's definitely less fluid that comes out in some gentlemen. It can cause a slight drop in blood pressure. Occasionally people will have dizziness, even fainting episodes. So if somebody has dizziness, initially it's probably not the best drug. There can be potentially fatigue issues and drug interactions with other medications. There's some questions about the long-term use of Flomax and these types of medications, whether it may have some other deleterious effects, but the studies are very early, and most studies have shown that it's safe in the long term. The other type of medication, the other alpha blocker that is commonly used, but is not generic, is called Rapaflo, and that is also effective. It's probably the most specific medication for the prostate, may have the fewest side effects, but it's not generic, so it's a bit more expensive. But if it's covered by insurance, then it's definitely a good option for a lot of patients. Rapaflo, it's called. The other medications are 5-alpha reductase inhibitors. The best known one is finasteride. There's also a non-generic medication called dutasteride that works a little quicker, but they work in a different mechanism by actually shrinking the prostate. They actually prevent the change from testosterone to dihydrotestosterone, which is the hormone that actually causes the prostate to grow. So it blocks that change. It takes about 3 to 6 months to get the maximum shrinkage of the prostate, and the prostate usually shrinks by somewhere in the 15 to 20% range, and that can be seen, documented on ultrasounds. That it definitely does shrink. It also does lower the PSA level by up to 50%, which can potentially interfere with prostate cancer's detection. So it's very important that your doctor knows whether you're taking this medication, because it can drop the PSA by 50%, and then you have to make adjustments for when to consider prostate cancer. It also can potentially cause erectile dysfunction, lowered sex drive, less production of semen, and also breast tenderness. So in younger men is probably not the best option. It seems to cause less of these problems in older gentlemen, but it is something that is highly effective. And for some patients, we actually elect to use both medications because they do work synergistically together. So a lot of patients that I have are taking Flomax and finasteride, and that's called maximal medical therapy. But other drugs can also be used in combination. So now we would move on to the minimally invasive treatments for an enlarged prostate, and with emphasis on REZUM therapy. Now, REZUM therapy has been out for over 6 years. There are extensive long-term studies on it, and it is highly effective. And I think, at least in my practice, it's really revolutionizing the treatment of BPH for my patients. And I've been extremely happy with the procedure. It's minimally invasive, and we'll talk a little bit more about how it is performed. It is a fairly ingenious, method of shrinking the prostate. I have done a similar procedure for actually probably 2 decades. It was called Prostiva, and it's a microwave treatment. Over the last 2 decades or so, there's been a lot of different ways of trying to shrink the prostate without surgery, and microwave has been used in many different forms. There was a special type of a catheter that was passed that had microwave energy on the end, and then patients would have to have this for like an hour in their bladder, and it would give a microwave heat to the prostate. And a lot of patients had good responses initially, but the responses were not as durable as we liked. And so there were multiple different companies that were involved. But I think that REZUM has really revolutionized it, and most of those treatments now are used infrequently. Prostiva did work quite well in my experience for a number of years, but there was fairly high recidivism or high retreatment rates because it did not seem to shrink the prostate as much as we wanted. So REZUM therapy was developed, and as I say, it's quite ingenious. All it is water vapor, and it's injected using a catheter, or what we call a cystoscope, and it's injected right into the prostate tissue, going transurethral. And depending upon the size of the treatment, size of the prostate, different areas are treated. And the whole procedure takes probably less than 5 to 10 minutes. It's a very quick procedure, even in the larger prostates. What happens is the steam, as it changes from water to steam, releases energy in the prostate. And that energy gradually infiltrates throughout the entire prostate that's causing the obstruction, the middle part of the prostate. But interestingly enough, it is not transmitted through the capsule of the prostate. The area where prostate cancer develops is a higher density. So the water vapor actually just is confined to the middle part of the prostate. And that is the part of the prostate that is involved, obviously, with the obstruction. So over time, then, this tissue will shrink. And it's about by 3 to 4 months, most people have almost complete resolution of the obstruction. It's quite amazing, and there's significant shrinkage of the prostate. I have been doing this long enough, and I've done it in patients that I monitor for prostate for bladder cancer. So I'm looking in their bladder periodically, and it looks, within 3 to 4 months, it actually looks like they had surgery on their prostate, like they had a transurethral resection or a green light. So it's almost considered as good as surgery, maybe 80, 90% of the shrinkage that's surgery, but it just takes longer for it to help the symptoms. So it's not the ideal for patients that are in retention, but if somebody has a catheter already and does not want surgery, it can be done. And up to 85 to 90% of patients that are in retention do eventually void after this treatment. So I offer it for all my patients that with moderate symptoms or patients that have responded well to medical therapy, but don't want to be on medical therapy, indefinitely for the rest of their life. So it is highly effective. The procedure now is done under it can be done in the office with either nitrous. A lot of urology clinics are doing it that way. How I'm doing it, though, is I'm doing it in the operating room under sedation. And sedation is not general anesthesia. All it is the same type of sedation that is used for a colonoscopy. So the procedure is not even remembered by most patients. So go to pretty much just don't remember and wake up in the recovery room. Also, if it's done in the office, it can be done with a block where we numb the prostate up using an ultrasound probe and then using nitrous. But in my practice, I have been doing it with sedation, and it has worked very well. And it is covered by most insurances. The procedure, most patients are in the hospital for maybe half a day as far as during the procedure and post. They do go home with a catheter. The catheter on average is left in for 2 to 3 days, depending upon the size of the prostate. For larger prostates, though, it may be left in for a little bit longer. I have had a few patients that took up to a few weeks to actually void, and there is now a device that can be placed for patients that don't void. That's kind of like a stent in the prostate, and so it does not require then a catheter, which is very nice. And patients, I think, appreciate that they don't actually have to have a catheter. And then as the prostate shrinks, then that is removed, and then they can void on their own. I would say I generally tell patients that they will have irritative symptoms and probably be voiding worse for the first 2 weeks. They definitely want to stay on the medications that they're on, the alpha blockers especially. And then by 2 weeks, most patients are back to their baseline. And then it's just a gradual process from there as far as a gradual improvement of their symptoms over time. And by 3 to 4 months, symptoms are usually dramatically improved. And most patients can actually come off of medications by 3 to 4 months. you can expect some painful urination for a few weeks, intermittent blood in the urine, occasionally passing some tissue. There can be blood in the semen and some urinary frequency, but there are treatments for all of those potential side effects. From my experience, up to 97% of patients are pleased with the results of the REZUM therapy and would recommend it to a friend. This is just a diagram that does, let me see. Yes, the diagram here on the left is the obstructing part of the prostate, which is tan colored. That's called the hyperplastic tissue. And the catheter is placed through the urethra, and the steam is ejected in multiple areas here into the prostate, usually about 3 to 4 injections in each lobe, and then another 1 to 2 injections in the middle lobe. And then over time, this tissue, as you can say here, this tissue actually regresses, and then it's just the catheter, the capsule of the prostate here that's left. There are other minimally invasive treatments, the prostate urethral lift called Eurolift, which is a device that's done in a similar fashion. It's done using a cystoscope, same idea, usually under some sedation or nitrous. And it's basically a fishing tackle, kind of. It's a nylon that is kind of injected to the urethra and actually physically pulls apart the lobes of the prostate. So the advantage of this is that there's immediate release of obstruction. So most patients do not have to have a catheter from the procedure, which is an advantage. But probably the main issue is that I don't feel that it's probably as long-term, as helpful long-term as the REZUM. And there is that fishing tackle there, which potentially makes further treatment down the line slightly more difficult. But I think the main issue with the Eurolift is that probably it's not as long acting, and there's higher risks of needing further treatment down the line. The other treatment that I do commonly for patients that have severe symptoms is green light laser therapy. I've been doing this now for, I think, over 10 years. It is sometimes used in combination with the TURP if somebody has a very large middle lobe, but most patients only need the laser. And the advantage of the laser is that it's quite hemostatic, and most patients, I would say 95+% of patients, it can be done as an outpatient. So they do go home with a catheter, but they do not have to be admitted. It does cause some frequent urination afterwards. It causes some burning with urination, some blood in the urine, the risk of a urinary tract infection. And like any treatment, patients will have urgency and frequency for a while, especially during the recovery period. The transurethral resection of the prostate has been around for decades. It is something I learned to do and used for many decades during my career. One of the doctors that I trained with, or his relative, is one that actually developed it in California. And there's been many different iterations. There's also a saline TURP, and there's also something now called the button, which is more of a vaporization kind of similar. It's kind of similar to the green light, but it uses vaporization, but it's not quite as hemostatic. So oftentimes patients do have to spend time in the hospital. So there are a lot of iterations of a TURP, but it is highly effective. And I think for a lot of gentlemen, that's perfectly fine to opt for a TURP because the long-term results are excellent, and it can be done in a very, I think, fast way. And recovery is also quite rapid within a few weeks for most patients. Actual prostatectomy, when you say prostatectomy, it usually involves removing the entire middle part of the prostate. For very large prostates, over 120 cc's, it becomes very difficult to do a green light laser prostate. It can be done, and I have done it, I think up to about 150 cc's, but it gets quite long. It can be 2 or 3 hours. And I think that other options are probably better in those size prostates. For many years, I was doing what's called an open prostatectomy, which is done through an incision in the lower abdomen, similar to when the entire prostate is removed. But it's basically, you can think of it as a the prostate as a say a grapefruit, and the capsule is the thick skin of the grapefruit, and then the adenoma is on the middle. And basically, you make an incision on the capsule, and then with your finger, you can actually shell out the middle of the prostate. And it can actually, when you're done, you have like almost a grapefruit size piece of tissue that is removed. And then you sew up the capsule, leave catheters and drains. So most patients are in the hospital or in the hospital for 2 or 3 days. They did very well, but the recovery was longer. Now though, that this has pretty much been changed to something called a holmium laser enucleation of the prostate, or HOLEP. And that can be done completely transurethrally. It takes a highly skilled, highly trained physician in this procedure. It does have a steep learning curve, because it's not something that we have been trained in initially. So it takes special training. But for somebody that has done this procedure, it's really dramatic, and the results are just as good as an open surgery. It is done actually in a little different manner. You actually find the plane between the adenoma or the enlarged prostate and the capsule, and you use a laser to push the adenoma into the bladder itself. So you surround that and push the entire enlarged part into the bladder, and then you have a large opening, and then you have to use another type of a resectoscope to actually suck the prostate tissue out of the bladder. So it's a very interesting procedure. It's very effective, but it does require somebody that's doing this procedure very commonly. So somebody that feels comfortable with it. So in summary, the treatment options are watchful waiting. First line therapies that we talked about are medical therapy, medications, the REZUM procedure, which I am very optimistic. It will be used more and more by patients, because most patients don't like taking medications entirely for the rest of their life. And this is a very good option. One other thing I didn't mention was that REZUM therapy does not cause any sexual dysfunction. For most patients, probably 80% of patients, it does not cause ejaculatory problems either. And there's no permanent implant with the REZUM procedure. So in my hands, at least, I feel that it's revolutionizing the treatment of an enlarged prostate. And I would encourage, if somebody's having moderate to severe symptoms, I would encourage patients to further investigate this option. The surgical treatments, green light laser, which is highly effective, TURP also, and the HOLEP procedure or prostatectomies. So I would encourage patients, if they have questions, to consult their physician and get a referral to a urologist if they have moderate to severe symptoms. Also, certainly discuss PSA screening if you're over the age of 55 and maybe even younger. So I think it's time now for some from Q&A.
Yes, we got some awesome questions coming in. Thank you so much, Dr. Rittenhouse. That was excellent. So the first question we have is, what would cause onset of bladder neck obstruction in a 60-year-old man who previously had no issues, and how is it diagnosed?
Yes, bladder neck obstruction, the way I refer to it is just the prostate is not enlarged, and yet patients still have severe symptoms. As I say, it can even cause retention. And we don't know what causes it. It's similar to this condition in children called posterior urethral valves, but it's somehow the muscle of the bladder neck, which is before you get to the prostate, enlarges or hypertrophy. So the muscles themselves actually spasm, and it can really almost completely shut off the stream. So it can respond well to medications, Flomax, Eurolift,